excited bringing you another edition of OB-GYN Chats, situated right opposite Lady Pohamba, Demashuya Suites. That's OB-GYN. I'll be your host, Ilka Platt, and I'm joined by our regular specialist, Dr. David. How are you?
Thank you very much, Ilka, for having me. I'm fine, thanks.
Great. You're looking very handsome today.
Yeah, thank you.
It's almost the end of the year.
Likewise, you are.
I thank you. We do this just for you. Remember, always share, like, and give this to someone that needs to hear this conversation. It's all about infertility, Doc. What does that mean?
That's my passion. So some of the common myths that we see is, I would say maybe for females, you find that the age issue. I think the reality is that the age does play a role, specifically those patients above the age of 35, we know a significant decline in fertility. So we're really advising that if you are closer to 40, maybe see a fertility specialist just for an advice and options that are available when you reach that age. Then other myth that we see is that if you have a child, especially among men, that if you have a child, it's not possible for you to be having an infertility problem. But the reality is there is what we call secondary infertility, and that is possible whether it's a man or woman. Then the other one that is very common is contraception. That contraception causes infertility. In reality, contraception prevents you from getting a child or fertile at that time. But the moment you stop it, your fertility is supposed to return to the normal baseline unless there is a problem. So if it's happening, then you must just seek help. It shouldn't be the contraception that is causing the infertility. So those are some of the common myths that I can think of in simplicity.
I'm glad that Doc also said males can also be the cause.
Yes.
And I think there's a stereotype that it's always the woman that can't, conceive. Is that also another myth, that it's mostly the woman's fault?
Most definitely, yes. But in reality, what we see in practice is that there is an equal distribution among men and women. About 30 to 40% of all the fertility problems that we see. Yeah. It's either, if you see the first patient, one has a woman, the next one is most likely to be male. So there's an equal distribution in terms of what we see in clinical practice.
Well, thank you for those facts. Yes. Maybe let's speak about the facts about infertility. What is the leading cause of a male or even a female not able to conceive?
Yes. If we are to look at females, the first thing that we need to start off with, that I always try to explain, to put it in simple terms. For a woman, you need an egg. So if there is not an egg, so meaning that there's a small number of women that have their eggs finished before they're technically age around about 40, that's when we see menopause. So some women have their eggs that get finished before the age of 40, which is pathological. So that can happen. It's one of the causes, but in a small percentage of patients. But then at the end of the day, once you have an egg, you need to release that egg every month. And that's why you have menstruation. So it means for you to have menstruation, you must have released an egg every month. So in some women, you find that they do not release their eggs as it should be happening. And if there's no an egg, you will not conceive. So that is what we call anovulation. You don't ovulate. And then the egg that is released needs to go through the tubes, what we call fallopian tubes. Then those tubes can be blocked. Specifically in Africa, we see that is one of the leading causes, where the tubes are blocked by infections, whether it's from sexually transmitted infections in the past, or even from previous use of unsafe termination of pregnancy or abortion, can be the leading cause of tubes getting blocked. And then subsequently, there's also other uterine factors, such as fibroids. If they are blocking the tubes, they can cause infertility. Other diseases, specifically endometriosis, if they actually releases toxins to the eggs and to the sperms, and technically that prevents that, also causes infertility in women. So that is, in summary, some of the leading causes of infertility in women. When it comes to men, again, for a man to conceive, you need, number one, you need sperm. Obviously, for you to have sperm, you need to be sexually active, and to be sexually active, you need an erectile penis. And some women have what we call erectile dysfunction. If you have erectile dysfunction, you might not be able to conceive. So that is it's a possibility. But then, even if there is sperm or semen, you might find that there is what we call low sperm count, or there is no sperm at all in the ejaculate or the semen. And that can be caused by many factors such as lifestyle, smoking, alcohol, even weight issues, obesity, or even being underweight can affect sperm production. So, and then there's also other causes that are related to blockage. You can also have blockage in the male duct system where the sperm needs to travel to be deposited in the female, in the vagina. That can also be affected as one of the causes. Or even in terms of lifestyle, like underwears, when the underwears pushes the testis closer to the body, and we find that naturally the testis is hanging away from the body for a reason as part of sperm production, that affects sperm. So these are some of the common factors that, so when there's a problem among the couple, then it's advisable that they must be seen together as a couple so that we can really see among all these factors that I just mentioned, where could be the problem.
Yeah. And it's good that we start there, because usually a couple would probably come after they've failed after numerous attempts to, conceive a child. When they get to the level by saying you are infertile, you aren't able to conceive, what are the processes from there? Are there, let's say, methods that they can conceive, and what are those options?
Yes, indeed. So the first step is always evaluation by the fertility specialist to be seen, and then our role is to look into all these factors that I spoke to about earlier. Look, where could the problem be? If it's, for example, a problem of anovulation, that is very easy to treat. We give you medication that helps you to ovulate, and then and most of those patients with that problem conceive easily. And then if it is other factors, it always depends on the first evaluate and make the diagnosis. Where is the problem? Although it is also important to note that there is a certain percentage of about 30% of women and of couple, not women per se, couple, that after even checking the male and female, you don't even find anything wrong. We call it unexplained infertility. And then even among those patients, there is then if it's unexplained, then there is also ways to help them, such as starting with a simple procedure, such as what we call insemination. You can do what we call intrauterine insemination, where you literally bring the sperm closer to the egg during a timed cycle where you know that the woman is likely to ovulate to this specific time. You put the sperm closer to the egg, and then it also improves the chances of a woman conceiving. And then other factors which are related, for example, male factor, where you don't have enough sperm or you only have low sperm count, then those factors, and for example, where you have tubes that are blocked, we know that procedures to really unblock tubes, they are also not effective. It can be done, and we have some success, but it's very small success percentage, less than around 10 to 15, up to 20%, but it's less. But then those are now the patients that you can maybe advise, depending on those, if there's males and blocked tubes, you may have discussion around what we call assisted reproductive technology. And assisted reproductive technology refers to any method of what we call handling gametes. Gametes is eggs or sperm in the lab, and then we put them together. We are able to fertilize them either by themselves, putting them in a dish, or we can even get a sperm and then you inject it directly into the egg, the procedure called ICSI, and then these embryos then start developing in the lab, and then at a specific time when the embryo is developing, typically around day 3 to day 5, we take that embryo and then we transfer it into the woman's uterus, and then the baby starts growing in the uterus. So those are some of the options that are available.
10 to 20% is very low, Doc. And I assume this is probably a costly exercise each time a couple wants to try. And how many times can you try? And when do you say, Doc, sorry, it's just not possible for you as a couple to conceive, maybe you can try adoption?
Yes, I think that's one of the limitations. When it comes to fertility treatment, the honest truth is that even in the best hands, the best is that best hands, best resources, there's always a limitation to the success rates of fertility treatment. It's never 100%. The most recorded best percentage is about 70%, meaning that 70% of the patients, couple that goes through fertility treatment will conceive. But again, that is depending on the couple in front of you. So you may find that if it's a young woman, then you know that they tend to have a better, what we call prognosis chances. But for example, if it's an older woman, then the prognosis or the chances of conception is also low. So it's all multifactorial depending on the patient's factors. Age, disease such as endometriosis, we know the factors are more. Other diseases such as adenomyosis, the success rates are less. Factors, obesity. So in terms of success, it's more of an individualized success. But depending on the condition, the success rate drops. Depending on your age, your success rate drops. But the younger the patient. So what you're trying to highlight here is that as a couple, if you have a fertility or you believe that you might have a fertility problem, try to see the specialist early enough, so that so that we don't come too little too late, especially closer to the age of 40 or even over the age of 40.
Yeah.
Yes.
Very difficult, Doc. You have a tough job, psychosocial support, emotional support. Let's focus on that. From family, even the environment. What do you advise even to someone watching that's been through this very, very unfortunate process?
Yes, it's not a secret that the infertility or fertility treatment journey is one of those emotionally, psychologically draining. One, mainly because obviously it comes with societal issues. If you look at society, especially if you, I'm speaking from my culture that I'm related, if you're a Vambo, you get married in December, the aunt,
where's the baby?
The granny is already asking where's the baby, without even knowing that the couple is actually going through some form of infertility problem. So psychologically, it is quite an emotionally draining journey. But we are advocating that the best way to approach this is that as a couple, they need to accept that there is a problem, number one. Then they also need to speak about it openly and in a constructive manner and seek help. And we are here. We also then, for us as a fertility specialist, doctors, not only that we are focusing on treatment, but it's actually what we call a multidisciplinary team. We have access to the psychologists also with the interest or further training in reproductive matters, that where we can refer them to help them cope with this very difficult journey. Then also other issues related, they also have access to support groups where we can refer them so that they become part of, and in the modern day age, there's accessible information, whether webinars, whether information on social media that are available to form as a support group to really help this couple understand, number one, that they are not alone, that there are also other couples that are going through this, and also to recognize that there is also help and hope, that there are many other ways. In a worst case scenario, then the last option would then be, like you are alluded to, that adoption can be the last resort where there is really, we have reached the ceiling and to say that there is no anything that we can do. But before adoption, there's also many other ways, such as, for example, doing what we call donor, where you get an egg donor, sperm donor. There's many other possibilities that can be done to really help the couple. But psychosocial support is also one of the treatment that is forming part of our treatment through the MDT support, psychologists, social worker, psychiatrists, if there's a need.
Great stuff. Doc, we appreciate, and we always say at the end, what are some of those services that OB-GYN offers to those that are going through it, and maybe perhaps how they can reach out to you and Dr. Simon? Yeah,
no, most definitely. So services in terms of, obviously, as obstetricians and gynecologists, we provide obstetric care, but obviously we also, from a gynecological point of view, we are working towards really becoming a fully fledged fertility center, and and that is why we are very much passionate about this topic. And so far so good. We are doing well in that aspect, and we are really encouraging those patients there that really have a problem out there that they believe that is related to fertility matters to come out, and we are here to assist them. Yes. And let us know it's okay to talk about such uncomfortable discussions, and that you're not alone. Doc, we appreciate. Thank you so much. Thank you always. Yes.
And we will be back pretty soon.
Very much, and I think for those we are traveling, it's December. We are wishing everyone to be safe on the roads.
Yes, please.
And we are wishing everyone a Merry Christmas and a happy and prosperous
Happy New Year 2026, Doc. Can you believe it?
Yes.
We have really come to the end of the road. Thank you so much. Subscribe, share the link, and we'll be back in the new year.